Hello dear viewers, in this video I am going to discuss the management of sepsis with regards to target consideration during its management. It means how much to do, what are the endpoints or limits with regards to each intervention. I am Dr. Sunil Garg from Essentials of Acute Care. Regarding intravenous fluids, administration of at least 30 ml per kg of intravenous crystalloid fluid as a part of initial resuscitation to be given within the first 3 hours of resuscitation if patient with the known or suspected infection manifests hypotension and or an elevated lactate. Patients who continue to have signs of hypoperfusion and volume depletion after initial resuscitation means after administering 30 ml per kg in first 3 hours, administer more boluses of balanced crystalloids. Or albumin can be given in such patients with the intention to restrict volume intake. Guidelines does not make any recommendation regarding restrictive versus liberal fluid therapy in the first 24 hours of resuscitation. For the assessment of fluid responsiveness, dynamic measures to guide fluid resuscitation is suggested over physical examination or static parameters alone. Regarding blood culture, guidelines recommend obtaining at least 2 blood cultures before antibiotics are administered, with one percutaneously drawn and the others obtained through each vascular access device, unless the device was inserted less than 48 hours beforehand. With regards to antibiotics, loading dose of antibiotic should be given over short duration as initial bolus, irrespective of organ functions. Thereafter, optimize dosing based on accepted pharmacokinetic and pharmacodynamic principles and specific drug properties. Empiric antimicrobials should cover for MRSA if likelihood of this infection is high. Use 2 antimicrobials for likely gram-negative infection if patient is at high risk of multi-drug resistant organism, and administer antifungal agent if high risk of fungal infection exists. Do not administer double gram-negative coverage once the causative pathogen and the susceptibilities are known. With regards to mean arterial pressure goal, guidelines recommend an initial target mean arterial pressure of 65 mm of mercury over higher MAP target. In patients with chronic hypertension, mean arterial pressure target is not yet established. The role of permissive hypotension means mean arterial pressure between 60 to 65 is currently under evaluation. With regards to the use of norepinephrine, start the infusion at 8 microgram to 12 microgram per minute and titrate to the desired pressure of mean arterial pressure. The suggested maximum dose of norepinephrine is 1 microgram per kg per minute. If patient mean arterial pressure target is not achieved with the norepinephrine dose of 0.25 microgram per kg per minute or more for few hours, add second vasopressor, and that is vasopressin, rather than further increasing the dose of norepinephrine. Regarding administration of vasopressin, administer it if the dose of norepinephrine reached more than 0.25 microgram per kg per minute or 15 microgram per minute and mean arterial pressure goal is still not achieved. Remember, vasopressin is given as a non-titrable infusion of 0.03 unit per minute as a fixed dose, and discontinue vasopressin if dose of norepinephrine tapered down to 10 microgram per minute. Regarding the use of steroids, guidelines suggest adding corticosteroid hydrocortisone in septic shock if there is an ongoing requirement of vasopressor therapy and the dose of 200 to 300 mg per day of hydrocortisone is suggested either as intermittent bolus or continuous infusion. Regarding lactate guided resuscitation during sepsis management, current literature does not support its value. Regarding administration of insulin to control the blood sugar, guidelines recommends initiating insulin therapy at a glucose level of 180 mg per deciliter or more and maintain blood sugar between 140 to 180 mg/cent. Regarding oxygen saturation, there are no suggestion of any particular level of oxygen saturation, but acceptable level of oxygen saturation ranges between 90 to 94%. With regards to tidal volume on mechanical ventilation, while managing adults with sepsis-induced ARDS or respiratory failure, using a low tidal volume ventilation strategy means tidal volume of 6 ml per kg over a high tidal volume strategy is recommended. Here, weight is based on predicted body weight. With regards to goal of plateau pressure during mechanical ventilation, while managing adults with sepsis-induced severe ARDS, using an upper limit goal for plateau pressure of 30 cm of water over higher plateau pressure is recommended. Plateau pressure higher than 30 means up to 35 cm of water can be used in patients with the poor chest wall compliance, like patients with obesity and abdominal distension. With regards to PEEP setting during mechanical ventilation, while managing adults with moderate to severe sepsis-induced ARDS, using higher PEEP over lower PEEP is suggested. In mild ARDS, there is no suggestion of using higher PEEP over lower PEEP, but the definition of higher or lower PEEP is ambiguous. With regards to prone ventilation during mechanical ventilation, adults with sepsis-induced moderate to severe ARDS using prone ventilation for greater than 12 hours daily is recommended. Regarding administration of sodium bicarbonate, adults with septic shock and hypoperfusion-induced lactic acidemia using sodium bicarbonate therapy to improve hemodynamics or to reduce vasopressor requirement is not suggested as long as pH is 7.1 or more. But for adults with septic shock and severe metabolic acidemia, means where the pH is 7.2 or less, and acute kidney injury when the AKI score is 2 or 3, using sodium bicarbonate therapy is suggested to reach the pH between 7.2 to 7.3. With regards to blood transfusion while managing adults with sepsis or septic shock, using a restrictive transfusion strategy over a liberal transfusion strategy is recommended. It means not to transfuse packed RBC if hemoglobin is between 7 to 9 gram per deciliter as long as there is no evidence of acute coronary ischemia, ongoing bleeding, or inadequate oxygenation. Here I finish. Thanks for watching this video. I would appreciate your feedback, suggestions, or comments. See you again in my next video on something very interesting. Till then, bye and take care.